Now, when we talk about unusual manifestations of usual infections, there are so many infections and there are so many unusual manifestations. This is like writing a book on ID and talking about each and every complication that is possible with every usual infections. So I thought let's analyze what are these unusual manifestations. Now, when we talk of any organism, we usually think that it's going to cause a certain set of disease in a certain form. Say, for example, tuberculosis. Tuberculosis has to cause pulmonary TB, or it can come with TBM. If TB comes with parotitis, which we've had recently, it's unusual for us. So anything that is unusual is deviation from the usual pattern. Now, what is the cause of this kind of unusual presentations? One is the disease is not responding in time. That's the most common unusual presentation. So if we have tuberculosis that's taking a longer time, you've given 6 months of AKT, still not responded. That's an unusual pattern. Or you have a meningitis, you started ceftriaxone and the fever is just not coming down. That's another unusual manifestation. Or an organism that has given you a very weird symptom. So suppose, for example, we talk about Staphylococcus aureus. We don't expect Staphylococcus aureus to cause meningitis unless there is some defect in the brain, in the skull, which allows the Staphylococcus aureus to penetrate. So why would a person just come with a staphylococcal meningitis? So that's a very weird symptom of Staphylococcus aureus. Or any organism that's not supposed to cause a disease, the non-pathogenic organism. That's in the other talk that I'm going to take about unusual infections. Infections that are not supposed to cause, organisms that they are not supposed to cause infections in humans. So these are unusual patterns of various infections. Why do these unusual patterns occur? It could be a complication of the disease, a known complication of the disease. For example, if we take a patient with meningitis and fever just not coming under control, it could be an empyema developing, or it could be a cerebritis, or it could be a cerebral abscess developing. So that's a known complication. It's an unusual pattern. We usually expect meningitis to go home in 10 days. This is an unusual presentation. Then there are factors that we have created that causes an unusual, especially in a hospital-based practice. We put in central lines, we put in urinary catheter, we put in proton pump inhibitors. Everybody who's on antibiotic gets pantoprazole or lansoprazole or omeprazole. So these are predisposers for fungal infection. So most of the times, in fact, recently I've come across so many colleagues or friends who've been hospitalized for some other issues, like say for angioplasty or for say hip replacement or something like that, and they'll end up staying in the hospital for a pretty long time because of hospital acquired infections. And these are all iatrogenic, and these are the causes that we are creating. So CVC lines, proton pump inhibitors, umbilical lines in the NICU. We all know about neonatal sepsis and how umbilical lines are causing problems. Unusual patterns can be because of wrong dosing. We are underdosing. Most of the times we don't remember the doses of drugs. We assume 1 year child means 5 ml twice a day. We don't even calculate the dose. Or we are using wrong choice of antibiotics. And what I want to really stress in this talk is most of your unusual presentations are actually because of the wrong treatment. Nothing else. It's major wrong treatment. Then we have organism-based factors. Now the organism is pretty smarter than humans. We've got artificial intelligence in them. So the bug is a resistant bug. We've got MDR TB, we've got MDR typhoid, we've got ESBL, we've got carbapenem resistant infections, we've got VRE, VRSS, name it. So you've got a resistant bug. That's why it's behaving so unusual. Or the organism has changed. In the morning somebody asked me, dengue is changing, H1N1 is changing. Yes, because the organism changes. And that's why we get unusual manifestations of a disease. We've got H1N1 now coming as neurological manifestations, especially in Japan. It's been reported, the neuropathy in them. So unusual manifestations because of the organism. Then you have host factors. If you have an immunocompromised host, somebody who's on cancer chemotherapy, somebody who's undergone a bone marrow transplant, liver transplant, then they get these unusual manifestations, uncommon infections. Like when we started HIV clinic and we saw the kind of infections, I tell you, we saw the whole textbook of infectious disease. Cryptococcal meningitis, I may have never seen cryptococcal meningitis apart from HIV. Toxoplasmosis, Cryptosporidia, Microspora, Isospora, name it, in every organism you would be seeing. Then, because of the host, again, if the patient is immunocompromised, then the regular infections also take a longer time to heal. Say, for example, TB in an HIV patient may not heal in 6 months. You may need to give longer, 9 months, 11 months. It's because of the body's immunity is not there. It's not because the organism is not is more virulent or the drugs are not working. But just as we give antibiotics and we expect 50% of the job to be done by our body's immunity, same way when we are treating any patient, we expect the body's immunity to be symbiotic with this. And then there could be host related diseases. Suppose UTI, we expect E. coli to be the organism most of the time. So suddenly you get a proteus, you get astonished, why is the proteus? You start looking for a renal stone. So these are the various organisms that can cause various problems, host factors. And most important, the doctors. Okay, what happens is we don't actually look for, because we are ignorant. And when we are ignorant, we really can't identify something that is just staring at us. So what the mind doesn't know, the eyes don't see or the ears don't hear. And that's where the problem is, because we don't really know. Ignorance is bliss. I think ignorance here would be foolishness. And sometimes we are so rigid. My family always tells me that doctors are the most egoistic people on the earth. Okay, because you're the only doctor in the family. So they say that even though something is staring at you, you don't want to accept it. So a lot of times it happens that we may be sitting in a conference, we may be sitting in a CME, there will be arguments, but everybody sticks to their own thing without probably no rational evidence, just based on experience or just based on a possible thought concept that what I say is correct. So even if the information is right there, our mind is not ready to accept it, and these are doctor factors, which are the ones which lead to an unusual manifestation. Then when the patient worsens, we panic, what has happened, what went wrong. So what happens to these unusual manifestations? Now there have been issues of these unusual manifestations. Say for example, Streptococcus pneumoniae. We know that ceftriaxone or penicillin works for Streptococcus pneumoniae. US, they've started seeing resistance to Streptococcus pneumoniae, the penicillin binding protein, and they've started adding vancomycin as first line agent to ceftriaxone for treatment of bacterial meningitis. So one of the outcome of these kind of organism related changes is that our treatment protocols have changed. Our treatment durations have become longer in some of the instances. Say for example, tuberculosis started off as 3 months, went to 6 months, went to 9 months, went to 12 months, back to 6 months. So depending on how we got various randomized controlled trials, treatment durations started changing. Then we started saying, oh, these unusual manifestations have to be prevented. So either we give a vaccine. If we don't have a vaccine, let's give drugs which prevent it. So we started giving prophylaxis for UTI. WHO has come out with a recommendation of INH prophylaxis for HIV infected children. They say every child less than 5 years, put him on prophylaxis in a developing country. That's ridiculous, because how can we have a child on INH prophylaxis 6 months, then after 6 months again put him on INH prophylaxis, after 6 months again put him on INH prophylaxis. So some things are iatrogenically created. We started sitting up and we said we are seeing too many unusual organisms, or we are seeing too many patients who are in the hospital for a longer time. Let's be rational in our prescriptions, and that's where the rational antibiotic policies came. Hospital practices in the ICU started changing. Hand washing came up in a big way. Isolation started coming up in a big way. We started talking about HEPA filters, UV radiation. All these started practices coming, and we started looking for a disease much earlier. We started pushing our panic buttons much earlier, especially in the ICU. A little blip of CRP, a little bit of CBC rise, thrombocytopenia, and we started panicking and we started changing antibiotics. So these are the outcomes of these unusual manifestations. Now I just wanted to stress on a few unusual manifestations of a usual infection. 6-month-old girl, fever for 3 days, 1 episode of GTC followed by drowsiness. There is no focal neurological deficit. She has a bulging anterior fontanelle and she has been immunized as per the EPI schedule. So obviously we are thinking of meningitis. She's got cells, 90% polymorphs, low sugars, high proteins. She's been started on ceftriaxone and dexamethasone. Her ultrasound brain is normal. Her latex later on comes as H influenza B. So you're correct in your treatment. Dexamethasone has been stopped after 48 hours. After 4 days of antibiotics, her fever still continues. Her sensorium has improved. Now you start wondering, why is it behaving like this? This is an uncomplicated meningitis. This child should have got better with ceftriaxone. Why is the fever just not coming down? So what could be the cause of persistent fever? Yeah, so we are thinking of a resistant bug. So that's exactly why I'm asking, should we change the antibiotic? Okay, so we do an ultrasound. So what are the complications? First, let's look at the complications. Why should a fever persist in Hib meningitis? Either it's in subdural collection or it's an empyema. There is an infarct that is occurring now. There's cerebritis, there is ventriculitis, there is cerebral abscess, or there is a hydrocephalus that is developing. These are complications. Not all of them are going to cause fever, but these are all possible complications of Hib meningitis. So obviously the first thing that you're going to do is repeat an ultrasound. It shows a collection of 0.9 centimeters on both sides, subdural. Now, should you change the antibiotic? What should you do? Okay, is ceftriaxone resistance known with Hib currently? No, it's not known as yet. So why shouldn't this ceftriaxone be working? So let us go, how long does fever persist in H influenza meningitis? So fever of H influenza meningitis is typically 4 to 6 days. So normally what we thought, we start an antibiotic in 48 hours, the fever should effervescence. It's not like that. It's unlikely that just an uncomplicated collection is going to cause fever, prolonged fever. What you could do is look at the I've been stressing on procalcitonin since morning. Look at the CRP, look at the procalcitonin. If CRP has decreased, white cell count is normalized, I wouldn't do a repeat LP also here. Just observe the child. So this child, we continued the same antibiotic, CRP came down, WBC count came down. Fever went away on day 6. Now the question comes to me is that, how long do I give this antibiotic? Ceftriaxone. For Neisseria meningitis, it is 5 days. For Streptococcus pneumonia, it is 7 to 10 days. And for H influenza, it may be from 10 to 14 days. So if you have a child who's received the Hib vaccine, your duration of antibiotics for meningitis would be 10 days. So in this child, because the fever came down on day 6, how long do I give this antibiotic? Yeah, so usually this is an uncomplicated Hib. An uncomplicated Hib treatment is 10 days. So in this child, treatment duration should be 10 days. So even though this was unusual for us, why was it unusual? Because we were not aware that Hib fever can last for 6 days. So our awareness was not there. So even, that's what I told you, doctor factors. Even though something's staring at us, our mind doesn't accept it. And if it doesn't accept it, the mind does not know what the eyes don't see and the ears don't hear. Let's see this patient. 5-year-old girl, she has a fall while playing, followed by which she is unable to bear weight on her legs, followed by which she has inability to sit and now move her limbs within 24 hours. There is no bladder bowel, there is no sensory loss, she has no difficulty in breathing. She's been immunized up to booster 2, has received pulse polio. She's had no preceding illness, injection or drug intake in the past 1 month. So this child, on examination, you see there's acute flaccid paralysis. Absent DTRs, power is less in the lower limbs, sensations are normal. She has severe pain in the lower limbs. Upper limb and cranial nerves are normal. She has, you're suspecting GBS, you do a EMG NCV, you find acute axonal neurodegeneration, there is no demyelination. What are we dealing with? What affects the anterior horn cells, the axons? Poliomyelitis. This child has received pulse polio. So is this an unusual manifestation of pulse polio? Is this, not pulse polio, is this polio in an immunized child? Or is this vaccine associated poliomyelitis? She's received up to booster 2. Vaccine associated poliomyelitis is with the first dose of polio. So which are the non-polio viruses? Polio is which virus? Enterovirus. So enteroviruses. So other enteroviruses. So with polio eradication, AFP has not disappeared. Polio has disappeared, AFP has not disappeared. What remains is acute flaccid paralysis still comes. Axonal degeneration still comes. And it's been replaced by the other enteroviruses, especially your Enterovirus 71 and Coxsackie. What happens is they behave just like polio, except the disease severity is lesser. So our goal of achieving polio free or AFP free country is not there. We've achieved polio free. But what we should understand is certain diseases which were not seen earlier have now emerged. It's not that these are unusual organisms. It's just that the disease has got replaced by one organism when the other was eradicated. So when smallpox got eradicated, we had measles and rubella coming into the picture. When polio has got eradicated, we have other enteroviruses coming into the picture. So now if we see AFP, we have to think of enteroviruses. And how do you diagnose enterovirus infection? Yeah, we have to do a stool examination. Just as we send stool for polio, we have to send a stool for enterovirus. So it's basically same principle as polio. So now when we start thinking, we don't even need to read. It's just logic that comes behind all these unusual manifestations. Now this is a 4-year-old boy. He's referred for a non-healing pulmonary TB. At 2 years, he's diagnosed to have pulmonary TB with an AFP positive. He's treated with 4 drugs for 2 months, followed by HNR for 7 months. So total 9 months of therapy. His chest X-ray continues to show the haziness. Then somebody gives him 6 drugs with ofloxacin, streptomycin added to the other 4 drugs. 4 drugs are omitted and then again HNR are continued. So for 2 years, this child has been on AKT. Now he's referred for further management. What are we thinking of here? We are thinking of MDR-TB. 2 years he's been on treatment, his X-ray is not resolved, he's had a non-healing ulcer. What do you think went wrong here? He was given right treatment, he was given 4 drugs for 2 months, HNR for 7 months. After that, what went wrong? After that, when he didn't respond, there was no way that we could have given this kind of a schedule of 6 drugs, give for 4 months and then go back to HNR. This was a time when MDR should have been suspected in the first place. So we went wrong here and we had an unusual manifestation, that TB not responding for 2 years. So we lost time. We lost time of almost 2 years by the time he's come. When he comes, he's cachectic. He's got bronchial breathing on the right intraclavicular region, bilateral Krebs, his X-ray shows a cavity, and he's got bilateral lung involvement. His AFP is positive still. Now the question is, he doesn't have money. Okay, so this is an unusual presentation. Now what do? How do you treat him? They don't want to go to DOTS. He needs to be put on second line AKT. Yeah, now the question is, you're going to start him on second line, which is going to cost him money. How can he not have money for the cultures? So you have to insist for the culture. So try and do the culture, at least not then prove by gene expert a rifampicin resistance. And this patient, that's what we did. We, through the program, got the gene expert done, which showed rifampicin resistance. So at least we proved that he was RR, and we started him on the second line, and now he's doing fine. The thing is, this child worsened in such a way that his PFT always remained abnormal. He's going to land up as a chronic lung disease, and he's going to have a very bad lung in the future. So even though he may be salvaged, he'll be left behind with a very bad lung. So this is the problem of an unusual treatment that we did. So we had an unusual treatment, we had an unusual presentation of an organism, and we had something where the doctor didn't think of anything. Now this is a 7-year-old girl. She's come with chronic diarrhea. She has hypocalcemic tetany. She's HIV infected girl. So she's got chronic diarrhea, hypocalcemic tetany. She's on cotrimoxazole prophylaxis. She had herpes zoster 2 years back. Now on examination you find that she has hepatosplenomegaly, lymph nodes, pallor, edema. So you investigate her for the chronic diarrhea. Difficult to get a scopy done in a chronic HIV positive patient because they don't want to infect the scope. So we did a barium which was normal. The stool showed 20 to 25 pus cells. She's been treated with ceftriaxone, metronidazole, nitazoxanide, flucon, calcium supplement, CD4 158. She started on ART. Now she does fine on ART. A month later she comes back again with diarrhea. And this time the stool shows giardiasis. This is an unusual manifestation because this child has been treated with metronidazole as well as nitazoxanide. This child's giardia should have gone away before the ART started. The giardia did not go. This child still has giardia. What is so unusual about it? The unusual thing is this child is immunocompromised. So, yes, this child is immunocompromised. So even after giving the right treatment, the organism may still persist. So that's an unusual manifestation of a disease. This child ultimately was treated as an IRIS, immune reconstitution, metronidazole with steroids, and that's when the child improved. So even when you have these unusual manifestations, it could still be that the organism is still behaving in the same way. It's just that the host factor is different, the doctor factor is different, or the environment is different. So most of the unusual manifestations are actually known manifestations of that infection. Awareness of the same is essential. Rational prescribing practices will prevent these unusual manifestations. Mind must strive to know these unusual, and it's just logic. You don't even need to actually read. You just have to interpret it by logic. The list of these unusual manifestations could be pretty long, but I thought I would just harp on these conditions so that we could, because brucella rickettsia was already being covered, so I didn't want to cover those. So thank you very much.